We will, as usual, ask you to please mute your lines and turn off your videos until the discussion and questions session, just to so that we don't get any feedback. Obviously, please feel free to use the raise your hand function to ask any questions, and please use the chat box as well to post any questions, comments, and we'll be monitoring that box as we go through the morning. I've already mentioned that we're recording. Next slide, please. Next slide, please. Lovely, thank you. So I'm just going to kick off with a quick welcome and introduction, and also with Jenny. So for those of you who don't know me, I'm Liz Cullen, Head of Clinical Programme for Maternity and Perinatal Mental Health for Hampshire and Thames Valley Clinical Network, but working across the South East during these COVID times. Jenny will be joining me for the introduction. Then Barbara from the Regional Mental Health Team will be presenting the core data pack for the South East region. And then we're really lucky to be joined today by Mary Pappin from the National Perinatal Mental Health Team, who's going to be giving the main bulk of the session in terms of the data and access target update. We'll have opportunities for questions and answers after Mary's presentation, and then some further opportunity for group discussion in terms of how we can best support you with the access target, and also in terms of next steps and moving forward. Okay, so I guess what I first of all wanted to say though is that we know how hard it's been for all of you working during the COVID pandemic. It's not been an easy time, and the outstanding work that you've done through this period is something to commend yourselves on. And so the purpose of this webinar is absolutely not to be used as a formal assurance process or to criticise the access target rates achieved to date. It's really an opportunity instead for us to work collaboratively with you to help you all to put things in place in order for us to achieve the access target going forward, and ensure that every woman who should be receiving support from perinatal community teams is able to do so. So it's absolutely about us working collaboratively together to look at how we will achieve the access target going forward. Jenny, I'm just going to hand over to Jenny a second.
Morning, everyone. Could I just ask that everyone's muted themselves? I can hear a little bit of background noise. Thank you. Yeah, I'd just like to reiterate what Liz has said. We really do appreciate how hard you've all been working during the pandemic, and this webinar is very much in terms of help and support to help you all reach those targets and make sure all the women that should be getting a service can access one. What I wanted to ask you very quickly was, could you just do a quick little sort of roll call in the chat box, because we want to make sure that we've got all representation from all the services in the South East, and some of you just come up as guest. It doesn't say where you're from, so could you just do a little line in the chat box to say what service you're representing today? Thank you for that. And that was all I was going to say at this time. So let's crack on with the webinar, and I'll hand over to Barbara.
Good morning, all. Hi, I'm Barbara Goss. I'm from the South East Regional Team, and I work in the mental health team, and currently working on this particular work stream for perinatal mental health. I'm going to just go through some of the information. It's going to be extremely short, so don't worry. Every month we get what's called the Mental Health Core Data Pack, and that gives us information predominantly on how each region's going to meet, or how they're meeting their KPIs. And for perinatal mental health, the main KPI is the access targets. Next slide, please. So with this particular slide, I just wanted to give you a bit of an overview on what the national picture is. As you can see, we are all pretty much in the same boat. The Southeast, has the lowest access rate at the moment, but that's not really our key focus, because we fully understand the challenges that obviously this data shows that have been experienced nationally. And to be honest, just echoing what both Jenny and Liz have said, we basically applaud all the work you've done, especially within the pandemic, to mobilise staff and still be able to produce a quality service to our patients. Next slide, please. So this is the latest data, and it's from June, from the core data pack. And it basically shows how on month, how we've been trying to access data stats here. What I like to do as part of the region is just use this as a foundation. This is where we are now. And then once we've gone through Mary's presentation, what we're hoping to do is give you the tools to start looking at maybe your data quality to make sure it's correct, and to look at your service level data and make sure that's correct. And then from there, we can work collaboratively with you to look at other ways in which we can expand our reach to the community, and then ensure that women can access all our services that we've got for them. So that's me. I'm going to hand you over to Mary now. Oh, sorry, Liz. I'm not handing over to Mary.
Do a segue. So thank you very much, Barbara.
Sorry.
Mary, no, brilliant. That's great.
That's me. Can everyone hear me?
Lovely. Thanks, Mary.
Yeah. There we go. I can hear myself, which is a little distracting, but I'll go through it. Yeah, hi everyone. So as Liz said, my name is Mary Pappin. I'm a project manager in the National Perinatal Mental Health team. And Barbara asked me to come along today to talk specifically around the perinatal access metric, what that actually is, what are some of the data sources, so places you can go to look at your local provider data, or how that's being represented in the national data set. And then I'll talk a little bit as well around other sources such as the analytical tool, which I'll come on to. And then I'll do, if we've got time, and I think we will, I'll talk around the outcomes CQUIN as well. I'll go through, but there will definitely be breaks in this for us to stop, ask questions, go over anything that I've discussed, but obviously pop anything on the chat as well that I can try and pick up. So if we go to the first slide. So this is basically what the perinatal access metric is, and apologies if this is saying anything that people are already very, very familiar with, but I felt it was helpful just to kind of a bit of a back to basics. What do we actually mean when we say the access ambition for perinatal mental health? What is that counting, or who is that counting, I should say? So for our access metric, we are counting women that are in contact with specialist community perinatal mental health teams. And in contact means women that have received at least one contact that is face-to-face or via video conference. So what is not included in our metric, which I will come on to the next slide, it's telephone contacts don't count, SMS, obviously email. And it's any single contact. So this is a contact that could be just an assessment, and it's felt that potentially that woman doesn't meet the criteria for the service, or it could be that there's one contact based on perhaps giving preconception advice, and that's all that's needed. So the metric is that community teams, face-to-face contact, or video conference. If we go on to the next slide, I'm clicking it like I can do it, but I can't. Thank you. So what doesn't count? So telephone contacts do not count, and there is a clinical rationale behind this. I know for other areas, or for anybody that works across different policy areas, potentially with children and young people's mental health and their metric, telephone contacts count, and it has to be 2 contacts. The difference with us is they absolutely do not count. And it's felt very much that it is the role of the clinician to explain the importance of being able to conduct a risk assessment that needs to be face-to-face or via video conference in current times, appreciating that there is a lot of telephone contact that will have occurred during lockdown, even prior to lockdown. However, it is felt clinically and particularly from a safeguarding perspective, that the cohorts of women that are accessing our services need to be seen, even if that can't be face-to-face. And also something that came up not too long ago that I hadn't had before is DNAs don't count. So there was a feeling that there was a lot of DNAs during lockdown and that those slots weren't able to be filled, and could they count towards the metric? They absolutely won't count. And there is no intention for the metric to change over long-term plan years. So I appreciate there's large changes to the way we can carry out contacts with women based on COVID, but there's no intention to change the metric based on the clinical rationale that formed it. Something I've added in here is that Birmingham service developed some surveys that now all clinical networks across England have access to and can use. And they're 2 surveys, one for patients, one for staff working in our community services. And these surveys are asking patients and staff questions around the use of video conferencing in perinatal mental health settings, but also about other contact mediums. So far we've just had a quick done a quick analysis of data that came back between May and September when these have gone out. And the preference of women is generally a mixed method approach. So women are putting forward that they would like to be seen face-to-face and via video conference alongside telephone contacts. And because we count just 1 contact, if a woman is seen via video conference or face-to-face just once in this financial year, even if she may have during lockdown only received telephone contacts, that will still count towards the access ambition. But yeah, very, very important to look at what is the preference of the women that are in contact with our services. In the appendix of this slide deck are links to those surveys for anybody who would want to have a look at those and perhaps use. Next slide. So I'll do a demo. I'll just kind of show the national data and how that's presented in a dashboard. But I suppose it's as me kind of caveating before we go into that, why there potentially might be differences in numbers from, or small differences hopefully, between numbers of women that you're seeing at a provider level and what is represented in the national data. So to be clear, women are only counted once in each financial year for the national metric. So even if women have multiple episodes of care or access to service in a different CCG area, perhaps later in a year, that one will only be counted once in the national figures. NHS Digital do that count by a person based on the CCG numbers, sorry, based on a person's postcode. Aware that a lot of providers use the GP postcode, so that may cause slight differences in the way that women are counted at a CCG level as well. And then one of the biggest, I think, issues or challenges we have with the national data set, so the mental health services data set, where we capture this data for our community teams, is the way in which the coding works for video conferencing. So it's understood that a lot of providers in their local systems are logging video conferencing appointments as telephone contacts, and there is a different code that needs to be used for that. So when the data is scooped up and put into the MHSDS, where NHS England and NHS Digital takes the data, it's not picking up video conferencing contacts if it's not coded as such. So the code for that is 03. And again, in the appendix for any, I don't know if there's data analysts or business intelligence people from trusts on here, but all of those codes are in the appendix that you need for perinatal, for contacts and for outcomes. So they're in there. Next slide. Okay, so on here I've just done a quick summary of the 3 data sources that are available to system-wide. So for anybody with an NHS email that is working in the perinatal mental health, these are accessible to you, these 3 data sources. So there's the perinatal mental health dashboard, which I'll show us in just a sec. And this is really, really helpful at any level, but particularly provider, CCG, SDP, because that will give you access, referral sources, caseloads, all the way down from provider up to a national level. The second is the analytical tools. So probably easier if I'll go on to the slides about those to explain what they are. But they give, as it says, indicative funding, workforce and access through all of the long-term plan years for the next 4 years. And then recently launched is an outcomes dashboard. I think NHS England loves the dashboard. This is very new, so we can have a quick look at that, but I'll probably come on to that more when we talk about the CQUIN. But what I'll do, and I've just realised I didn't check this through with Liz, am I able to share if I do request control, can I share my screen quickly and just have a quick look at our dashboard?
Of course, yeah.
I think I need approval.
Yeah, there we go.
That me. There we go. And then if I share my screen.
Sarah, if you stop sharing a minute.
So can everybody see, can you just see Google?
At the moment, yes.
Fab, okay. So how to get into the perinatal mental health dashboard is there's a link on that slide, but also an email for anyone that hasn't seen this or hasn't had access, that you can just pop an email to, and we can give you access or send you a link. So login. This workspace has a whole host of information for anyone that hasn't seen it that's useful of perinatal mental health, but in terms of the dashboard, we would come here. Okay, so if I make this full screen, hopefully it won't be too tiny. So if I go, so this is essentially a Tableau report for people that are familiar with that. And if I go here, so this will show you access. As I've said, you can pick from a CCG, national, ICS, SDP, regional level provider. So if we were to go to a regional level, and then Southeast. So at the minute, this will give you each of the 12-month rolling. So this one for March will give access for the whole of 1920, April last year until March 2020. You can also break down by in-month. So again, you can do this at a provider level as well, which I won't go into here. So how many women have been seen each month, and then cumulative, how is the region looking overall? There's also benchmarked access, so that is nationally a breakdown to kind of see where you're sitting, and again, that can be done at all different levels. And then we've got caseload demographics, which are really, really helpful with the benchmark, particularly looking at, say, proportion of women on caseloads from areas, deprived areas, having a look at, again, sorry, you can do this at any level. So go, again, provider level data is in there. Proportion of young mums on caseloads, and then looking at ethnicity as well, particularly key for work at the moment. If there isn't local data that you have access to easily, you can come onto the dashboard and look at proportions of caseloads by different ethnicities. So that is that tab. And we've also got referrals as the fourth, or if we added this fifth tab. So referrals, I think, really interesting for seeing the impact of new referrals during lockdown months. So what was the change? So if I do region, and again, not doing an analysis of this data here, I think that would take quite a bit of time, but really just to show you what is available on this dashboard and how you can use it. So if we look at the Southeast, oh, I can't get up to my other tab. Give me 1 second. Sorry, this is proportion. This is caseload in month new and closed referrals. Sorry, the tab I'm referring to is the new referrals tab. So on here you can see referral sources. So where are new referrals coming from rather. So if I do this for the region. So these are all different referral sources that we have here. So you can look at health visiting, maternity, primary care, secondary care, self-referrals, what's the impact of those during lockdown, what's happening to those now, and then also importantly, missing or invalid, which is actually quite a high proportion on referral source. So again, that's a coding issue that needs to be looked at. But you are able to have a look at each of these referral sources and then it's benchmarked nationally. So for any reason, perhaps from a provider level, is there a different pattern in your referral sources, say for primary care or health visiting that differs maybe from the national picture? And then you can have a look into that a little bit more. Am I able to move that? Give me 1 second. And data quality is the final tab that you're able to have with me. So this is able at a provider level to look at, are there any months that where no data was submitted to the MHSDS? And this happens a lot, if I'm honest. The Southeast actually, compared to any other region, has submitted data very consistently. Will show you, if you're able to look at a provider, anywhere that's highlighted in blue is where there isn't a submission. So that doesn't mean that obviously no women were seen or that data wasn't provided. It means that perhaps one of the essential fields for perinatal mental health, and there's 6, was missed. So then NHS Digital just rejects that and it comes up as a zero, or excuse me, or a submission date was input incorrectly. It can be really small things, but it will reject that entire month. So you're able to quickly come on here and see over the course of this year so far if any months are missing. So data quality tab and then the metadata tab is really useful for giving an explanation of how this data is counted and what is it counting. So for all those different areas in the dashboard. So I'll stop sharing 1 second and hopefully come back. And then I don't know how I give control back, but hopefully people can see my face now rather than the screen. Is that right? Yeah, lovely. Thank you. So the dashboard has a lot and it is there to be used however you wish or what is helpful for you. In the appendix, I've done like key considerations of data. So things that you may and most likely are already considering when you're looking at things like referral sources, at the access trajectories, looking at caseload demographics. But as I say, Appendix 4 has as key considerations to think about for that data. But it is a tool that is there for us, so changes can be made to that. So if this is a tool that you're going to rely on and use as a provider, as an STP, as a CCG, and there's things that you think could be better, please email me or use the email on this slide as well. As I say, it's there for us to kind of support us in kind of looking and kind of at what is happening in services, and if there is data in there that isn't correct. So for example, if you're looking at access and you feel those numbers are way off from what you've got in your local system, then that is something that definitely needs to be explored. Is that a data quality issue? Most likely if the numbers are very different in the national data set to your local system. So please do go on and have a look. The analytical tools, if we go on to the next slide. So it's called a tool. There's 2. There's one at an STP level and one at a CCG level. It's called a tool, but essentially it is just a spreadsheet. So these are available online when you log in, just as I did for the dashboard. And they show for the whole of the long-term plan what those national access numbers are broken down. And it also does this in funding and workforce, which I'll talk about. But essentially it's saying, okay, so in the implementation plan that came out for the long-term plan, there's this big number that nationally we have to achieve as England. And what these tools do is break that down at an STP level and a CCG level. So what does that number actually mean more locally? So it does that from 1920 through to the end of the long-term plan. It also does that with funding. So it's the first time we've ever been able to be that transparent, I think, as NHS England over funding. So it's very explicit around each year. This is the baseline funding that you can expect. Each year, this is the transformation funding. And then it gives indicative workforce numbers again. And I really stress that because at all on the workforce, it is supposed to be an indication of the levels of workforce in terms of expansion over the 5 years. So there's a link there to that tool. I'm happy to go and show it, but like as I say, it is a spreadsheet. There's tabs, there's perinatal, there's an assumptions tab and how to use and interpret the tool on there. So yeah, if we go on to the next slide. So I've probably covered, but what's it demonstrate? Definitely shows the rapid increase in access that is expected for perinatal. Certainly done prior to COVID, when there may have been other further challenges around that, but it does show the real intense increase in the numbers of women that are expected to benefit from services over the 5 years. As I said, it goes into the funding as well. What it doesn't do is show kind of the role of perinatal MDTs in providing training across the whole pathway. So that's a core function of teams. It doesn't go into things like that. It doesn't kind of focus on quality of care for women. It's very, you know, these are the access numbers. It doesn't kind of go and service leadership. So all of those other things that are integral to services and services expanding well. That's not what this tool is about. It's very much about I think planning and assurance. Is it worth me stopping there and seeing if there's any questions before I go on? I feel like I've been talking for a little bit. Is that helpful?
I think it would be. Has anybody got any questions? Either raise your hands, don't forget to put your videos on and take yourselves off mute, or post something in the chat box.
It's helpful to know if people are familiar with that dashboard or not. I mean, happy if there's no questions, I can keep going.
Is it, I guess my question to everybody is everybody still with us? Is this all
yeah,
for me that was a really good walkthrough, and we've obviously mentioned on previous webinars like the analytical tool and that in terms of people planning for MMHS services and that, but just do we have everybody still with us? Is everybody still keeping up? Brilliant. Fab. Okay, we'll let you carry on then, Mary.
Let's crack on. It is morning and we are talking about data, so it's not the best. Multiple submission model. Again, some people may be familiar with this or not. Bob wanted this brought up in terms of what this could mean for resubmitting data. So last year, if you submitted data and that data got rejected by NHS Digital, you had a really small window of time, or I guess the trust did, to resubmit that data. If it wasn't resubmitted in a 2-month window, that meant that data was lost. So that meant women could have been in contact with services that weren't recorded. And I think that's a big reason why some of the access numbers are below what we would have expected for 1920. So women were seen, it just wasn't reported. For this year, you can resubmit data at any point in the year. So the idea is obviously submit that data on time accurately each month to NHS Digital, to the MHSTS. So that is your local service data getting scooped up by the trust to then dump it into the MHSTS. And again, Barbara, I don't know if this is the right audience, if there are analytics or business intelligence people on here, but it's really to stress that point that resubmissions can be made at any point in 2021. So if after this or through work that I know Barbara is going to be doing, when looking at access numbers, if there are large discrepancies in the numbers of women being seen for this year, and that's a data quality issue, there's an opportunity to have that data resubmitted. So worth doing that sooner rather than later, so it's not a big resubmission perhaps at the end of the year. Links to more information on that Yes, Liz, hi.
I was just going to come in to say, if you haven't got your data people on the call, which I know some people, we're going to try, some people may not have done, please feel free to send them the slides and the recording after the webinar, because I think it'll be helpful for people as well.
Yeah, definitely. Thanks, Liz. So next slide. Fab. So access in the southeast. So I've just done this high level, again, using the dashboard that I just went through to pull out what the data is saying for access in the southeast region at the moment. So the 4.65% figure that's showing there, that is a figure based on all of the access data for 1920. So all that's done is a rough, not even a rough, I guess, a quick projection based on 1920, all of the data submitted across the region for each month of last year. And taking that pattern of growth, what does that suggest? So where does that suggest services will be at the end of 2021? And currently, based on access for last year, it's saying for the southeast region that's 4.65 of the 2016 ONS birth rate. So the birth rate percentage or access ambition for 2021 nationally is 7.1%. Based on growth across the region for last year, Southeast would be at 4.65%, which is obviously quite a bit below the 7.1. Appreciating obviously that this year has been heavily impacted by COVID, but to stress this was based on last year's growth. So this isn't anything that relates to access for Q2, Q3 this year. Positives around data quality in the Southeast is that looking at 1920, there were no months where there were complete misses in submissions. So I have talked about the fact that if that does happen, there's obviously opportunities to resubmit, but some data is being submitted consistently to NHS Digital for all services across the Southeast, which isn't happening in any other region, which may suggest that there aren't data quality issues behind perhaps the slack in growth. It is actually that the data being reported is fairly accurate. But again, for you to interrogate the data on the dashboard to see that, it may be that actually the numbers of women haven't increased as much as perhaps expected in the first year of capturing the national data. So for last year, 5 out of 6 STPs across the region didn't meet their access ambitions. So that's the number from the analytical tool sheet that gives STP level numbers, and then looking at the providers within each of those STPs to see if they met that number. Kent and Medway did, quite largely exceeded the numbers expected for 1920. Resubmitted data, really nice to see Surrey and Borders Partnership did resubmit data for 1920 and increased by 1.4%. Others didn't, but appreciating that the time in which we had this great resubmit data for perinatal, you know, it was our first year of even submitting to the mental health services data set, came at a point when lockdown had just hit heavily. So the opportunity to do that was in April and May. March and April, so probably a time when the focus on resubmitting data wasn't at its highest given other things. And just some from the latest data, although we've got June, apologies, I've only got May in there, but just for looking at the caseloads for services. So again, you can do this at a provider level, but just for the region, 7.3% proportion of caseload were women aged between 16 and 20. So around the middle nationally for the numbers we'd benchmark for women below 20 on caseloads. 68.4% proportion of caseload with women reported as white or white British. Again, that's more meaningful when you've got local data or local demographics to set that against. So is that what you'd expect? And then 13.7% of women living in the most deprived areas. Again, having local data on deprivation will be a really nice benchmark to see whether 13.7% is what you'd expect. So that's kind of a quick look at Southeast access. Obviously here not going to go down into provider level access. I know Barbara's going to be doing that. Next slide. Or unless there's questions on that slide. but obviously we can come back to that. I would keep talking, but I'm trying to remember my next slide. I know there is a delay with Teams, so I'm going to wait.
Is it your
So,
slide case for investment?
oh, there we go. Yes.
Yeah.
Yes,
I
it
think
is. Sorry, I can remember if it was the CQUIN or this one.
For you.
Yeah, lovely. Thank you. So I've put this in. There's some slides that I've shared with Barbara that were used or developed last year and have been tweaked slightly. And they're really helpful at a commissioner level for presenting the case for investing in perinatal mental health. Now, again, it's up regionally to understand what the rationale is behind lower than expected access numbers into services across the region and certainly growth last year. But if there are can I use the word issues? I'm trying to be so careful. If there are challenges around investment and making that argument at whatever level, hopefully the tools that I've shared or slide pack that I've shared with Barbara will really make that case. But there is money available for perinatal mental health. There's a huge allocation, or more than we've ever seen, that will continue across all of the 5 years. So that is outlined there. So by the end of the 5 year, oh, I nearly said 5 year forward view, long-term plan, 239 million nationally. And there is whole system benefit. So there is, and I'm sure this is the case made across all of mental health, and it shouldn't be that services are pitted against each other, but there is money going into other areas of mental health. And I feel we need to be as protective as we can be of that allocation for perinatal based on the benefits expected across CYP, adult, A&E or physical healthcare settings. We're looking at mum, we're looking at baby. There is such a case to be made, and if there are challenges around investment, that is definitely something to raise at a regional level, if that is having an impact on access, on workforce, on growth, anything at all. So yeah, do contact Barbara if those slides would be useful, but that's just a bit of a snapshot on those. If there's no questions, because again, I'm just talking data and I guess there's nothing particularly at a provider level I'm going into on access, I can move on to the CQUIN. I feel like I'm getting off very lightly for questions. I normally get questions about the dashboard, everything in there, but perhaps I was a bit quick. Thank you. So constant talk around access when we know, one, there's other flexible ambitions to consider for perinatal and how they might impact the experience of women being seen. But just in terms of that experience of women being seen, we have the ability to record outcome measures. I did quickly look at the dashboard. I know I didn't go on to the outcomes dashboard that's on a previous slide, but this is it's essentially showing women that have paired scores, so women that have received 2 contacts from a service with an outcome measure. So what proportion of women on all of a caseload are receiving over 2 contacts and have 2 outcome measures recorded. So that's what that dashboard will show. But I did have a quick look for the South East, and actually outcomes data is recorded fairly consistently and certainly above average for all other areas in England. So from an outcomes perspective, South East is doing really well. So this is really just to reiterate things that everybody on here will know, the importance of capturing outcomes, the guidance that's available. So this is about implementing outcome measures, and it's specific to perinatal mental health settings. So that's MBUs and community. And then the framework for routine outcome measures in perinatal psychiatry, there's a link to that as well from RC Psych. For the data people, if there are any on this call, there's also a link there to the tools that can be flowed to the MHSDS. So it's a National Clinical Consent Repository, the NCCR, CCR, and that will give a list of all the coding for those tools for the MHSDS. So what does this mean for CQUIN? So if we move on to the next slide. So I'm sure most people are aware there was a national CQUIN announced for mental health that was around community for capturing outcomes in community mental health settings. This is across all of secondary mental health. For perinatal, our CQUIN is joint with CYP. It was felt some of the numbers were too small because they were having to base our CQUIN on 18-19 data, which felt a little unfair for perinatal because we only started really submitting our data nationally in 1920. So that is why it's joint for this year. So that was the CQUIN that was expected to go live in 1920. Because of the pandemic, it's now going to go live from the 1st of April 2021. There's a number of CQUINs that were released by NHS England. I suppose to simplify a lot of text on this slide, it's essentially saying that all of our mental health trusts will opt in to the perinatal CQUIN. There's a choice of it goes where is it, the total number, I'm trying to find it, apologies. So it's saying that there's essentially you have to have 5 providers will take up 5 indicators relevant for a provider. There are only 5 for mental health, so it's not that trusts or CCs are having to make a selection from a wider pool. All of those CQUINs that have gone out under mental health are relevant to mental health providers. So we would expect all CCGs, all provider trusts to be opting into the CQUIN for CYP and perinatal outcomes. Go on to the next slide. Thank you. I feel like I should have it in my brain so I can talk earlier, but the CQUIN is something that's just come back onto our or my workload, given that it was delayed for around 8 months. So the threshold, so for achieving the financial payment for the CQUIN means achieving 40% of children, young people and women in the perinatal period accessing services and having their outcome measures measured at least twice. It is at least twice. Obviously, we know with outcome measures, it's routine, it should be a routine collection, not just a kind of referral based and discharge. We're counting that on referrals with the same outcome, where the same outcome measure has been recorded. So to be clear, for this CQUIN, it is about 2 contacts. It's ensuring over 40% of those women on caseloads have had 2 contacts, and of those 2 contacts have had an outcome measure recorded, and it's the same outcome measure. The important point to remember is that it doesn't matter what outcome measure. So there is nothing to dictate which outcome measures are being used. If it's a core 10, if it's a prom, crom, prem, all of that will count provided it's the same outcome measure that is used. So next slide. Which may actually probably say what I've just said. Oh, so yeah, it's a bit of a repetition, but just to say, yeah, not limiting the outcome measures that will be accepted for the CQUIN. So reporting, so in the dashboard you can report, we will be reporting the types of outcome measures as a contextual measure. So you can actually on that dashboard at a provider level see of your caseload, total caseload, which women are eligible for the CQUIN. So i.e. those women that have had 2 contacts. Obviously we've talked about 1 contact. Is important to service but wouldn't count in the CQUIN, and which of those women received had an outcome measure recorded and which outcome measure as well. So it will break it down, but that's not important to the payment with regards to the CQUIN. And that is all from me. There's a lot, so I said there's the appendix there that has things like the survey links that I mentioned. It has all the coding for the MHSDS for the outcome, excuse me, for the access metric and the outcome CQUIN, and it has key considerations for the data. And
Mary, I've just popped up because I see that Lauren has put a question in the chat box, and I've also got one myself because I still don't really understand the pairing, and I don't know, I'm hoping it's not just me and there's other people on the call, but could you just talk a bit more about the pairing with CYP and what happens if your trust doesn't have that service? What happens if it does? Can you fail in a CQUIN if CYP, you know, if you're paired, does one score pull the other one down or raise it? Can you just do a bit of that and answer Lauren's question as well?
No, I absolutely should be able to do that, and I'm trying to remember, apologies, because I sort of was very late to prepping on the CQUIN for this, as I didn't know we were going to cover it for today. I need to go back and refresh on that myself. It's a separate team that deals with the CQUIN. I know that there's a reason, and I'm really sorry for not being able to explain it clearly here, as to why you wouldn't be disadvantaged in the CQUIN if, for example, you're a perinatal service that doesn't have, or is a provider that doesn't have a CYP service. So you wouldn't be disadvantaged, but I need to kind of go back to the Q&As for the CQUIN, which I can definitely share after this on that. Because it shouldn't be that, okay, so CQUIN, if CYP, is this what you mean, Jenny, with, I know we've talked about this about a year ago, apologies, where if CYP potentially submitted, say, only 20% of their scores had paired outcomes, is it expected that perinatal then was expected to do the other 50%? Like, is it weighted evenly, or is it just as long as of all young children, young people, and all perinatal, 40% of total caseloads? Is that the question about pairing? Yeah, I need to go away and find that out, but I can definitely do that today and share around with Liz to share with the group on an email. It might be useful to have text on that anyway, if there's questions that come up in the future. So I'll do that. Is it 40% of the access figure ambition, or 40% of the women that access the service? So it's 40% of women that access the service that received 2 contacts. So women that are eligible are women. So I suppose in a sense it is the access metric, so not the ambition. So it's women that received a face-to-face contact, 40% of women that received a face-to-face contact or a video conferencing contact twice. The expectation is that anybody that had more than 1 contact with the service that was face-to-face or video conferencing, 40% of those should have a paired outcome score. And if they do, then the CQUIN will be paid. What happens when you don't have a CYP in your trust? Yeah, so there's around 2 or 3 services in England that don't. I'll come back to you. You aren't disadvantaged, and I know that sounds really hollow because I don't have the rationale behind it, but I'll include that with the wording that comes through around the pairing with CYP. Apologies, I can't answer that today. I'll go to the CQUIN team.
I'm just popping up to say I would have thought 40% was really achievable, surely, in terms of paired outcome measures. Are any clinicians on the call care to comment on that? I would have thought this was a good one for perinatal, because surely we're going to have at least 40% of the caseload with paired outcomes. Yeah.
So the national data that the team used that I did look at, it for perinatal, we exceed that like easily. So there should be no reason from a community perinatal service perspective why this isn't achievable.
Great. And we've got somebody with a hand up. Emily, Em, do you want to ask your question?
It was just going on from you, Jenny, just to say, I think just to someone who's one of the team leaders, and we're looking at our outcome measures a lot. We've got to admit we've struggled with our core. Our clinicians are really good at doing it at assessment, but not so good at doing it on discharge. So that's something we've got to push more, but we're getting really good outcome measures for specific interventions, if that makes sense. So when our nursery nurses are doing work at the beginning and end of that intervention and psychological interventions, it's entering and exiting our service, I think we need to improve on, because unfortunately I think we're getting quite low numbers of discharge core. So yeah,
although for the CQUIN it wouldn't, I mean obviously that's really important to do at discharge as well, but it would be at any point. So if there were, even if the second measure was, say, for core was done, say, partway through treatment, that would still count. It doesn't have to be at discharge, although obviously from a clinical perspective that would be preferred.
Yeah, but that might be a really good thing to take back to the team, to suggest that as more of a maybe interim review, because it might improve. I think sometimes at discharge there's lots of other things you're thinking about as clinicians, and so that might be why we're getting quite low numbers. So that could be a good idea to pick up on numbers, is that actually we do it more as a midpoint kind of
or at
review.
CPA, or you know,
I think we can
points, couldn't you, in treatment? There's a couple of hands up as well, Mary. Emma, are you done?
Yeah, sorry. Yeah.
I don't want to rush you off if you had something else. Okay, so I saw Joe Spores. I didn't see the other name.
I was just going to say actually, linked to Emily's point, and then also linked to what Lauren's just said in the messages, that because of the COVID restrictions, quite often when you're discharging a patient when they're well onto their recovery path, you're not going to see them face to face necessarily. So actually completing the core can be more challenging if you're trying to do that over the telephone or on a video conferencing call. So I think that adds into the complication of trying to complete that outcome measure at that point. It was just a comment really, more than anything else.
Are you able to like share a screen and have it on a screen like this? Is that something that can happen with video calls with clients?
I mean, yeah, it could do. I think I think coming back to something much earlier in your presentation, a lot of our clients actually prefer the telephone contact to the video calls, so they find that more straightforward. But yes, you could share, in theory, she says, not having done it before, but you could share the Rio electronic notes page that has the core 10 ready to go there to fill in. So theoretically you could do that. Yeah.
There's sorry, Jenny.
I was just going to say Lauren's done it, but says core 34 is a lot to do, but she hasn't done it.
I agree.
Yeah.
And I suppose from that point around women's preference, I guess there are, I mean, Jenny, you'd probably talk to this better than me, but I think it's a lot of time to take up with an individual, where ultimately for a risk assessment to be done thoroughly, that needs to be face to face, and that needs to be all video conference, obviously. So if doing a lot of that work on telephone, I think there needs to be a real kind of explanation as to the benefits for women, and certainly from a safeguarding perspective, if we're considering women that have babies with them and being able to see mother with infant.
I'm slightly different. What I was meaning is that you're seeing the patient face to face at the start of their treatment, when they are clearly needing the assessment, they're needing the input, they're red rag rated, you're going out to see them face to face. And then actually by the time that you come toward the end of their contact with the team, they may not necessarily be, they may be amber or green rag rated. At that point, you're not really meant to be going out to face-to-face contacts because of COVID restrictions. So actually you are going to be moving toward doing video or telephone follow-ups. So that,
sorry, no,
I wasn't just talking about telephone the whole way through.
No, that's me. Given I think there's a lot of commissioners coming in on kind of telephone contacts counting for all. I completely missed that early part around assessment. Yeah, 100%.
I mean, I will grasp the telephone clinic nettle here, because I know it's really important for you know, it's been a massive issue talking to teams. And one of the things which I do think is a bit mean is that if a woman's offered video but chooses telephone, I really think those contacts ought to be counted, Mary, because that's patient choice. So I don't know if there's any thinking, because I know that the national team had held quite a hard line on the phone, but I do think that would make such a difference, because you know, that's out of our hands then, but we've offered.
So I guess the feeling from national clinical advisors on this is that only one contact needs to count. So if women prefer telephone contact, but actually just there needs to be an explanation, or this is the feeling, where at least an assessment, that initial assessment, is done on video conference or face to face, and telephone contact may continue after that. It's not saying this needs to be consistent throughout, but I think there's a feeling, certainly from Giles, others, that there needs to be at least one contact with that woman where she is seen face to face or for video conference, where she is actually seen, particularly from a prescribing perspective and a mother-infant intervention perspective.
What I've been able to collect that data, and then what I'd really like to do is to give it say 6 months, and then to look at those numbers, because if they're significant in terms of the access data target, then I think we might have to have another conversation. but it may be it's not as many as we think, but it feels like you know, and I do feel for teams if they're offering but it's declined, that it's not their fault.
Yeah, 100%. I think capturing that data around why women are declining video conferencing or face-to-face, and it will be interesting, certainly from those surveys that have been used, because there are questions around that and preference. But I think alongside those numbers, it would be really helpful to understand why women are declining that.
And it comes into like digital poverty and health, you know, health inequalities as well, because a lot of the teams that are already capturing it, a lot of them are saying that the women are saying it's financial because of the data.
Don't have data. I know.
Video. So you know, I do think we need a bigger conversation about this. So could I just do a shout out to everyone on the call to make sure if people are turning down video, that you're in preference to the telephone, you're collecting the numbers and the reasons, and then we will do something with that data. We'll give it, say, 6 months, and then we'll look at it again, okay? And we can sort of get Mary on board.
Definitely, please do. And definitely the point you make, Jenny, around it being a financial issue, like this came out straight away. I mean, this is coming out even before COVID, but the kind of highlight being, you know, there was capital funding released, not specific to perinatal, to try and support teams with digital interventions. But actually, if we're thinking about supporting teams, is there going to be funding that could support women that the teams are actually seeing? So some of this could be a rationale for that. So
So, if you don't mind me asking, I just want to refer to a point that you raised a little bit earlier about the Core 10 being completed for the second time on discharge and being paired, and it being difficult to do through the telephone. I was just wondering if you could tell me a bit more about where the difficulties are arising with that.
Was that a question for me? I think I don't think that I have specific examples. I just imagine that might be one of the reasons that it is more difficult. I was picking up on another point that Lauren had made. It can be more difficult to complete some of the outcome measures if you're ending the point of contact with telephone or video conferencing rather than doing it face to face. It's just a generalized point of why that might explain why we're getting more data at the beginning of assessments when we're seeing women face to face and having that opportunity for a longer conversation than it is at the end of the contact.
Okay, we've got 3 hands up, and I'm not sure who's been waiting the longest. So I can see Helen's name there, but I'm sorry, I can't see the other names. So should we go to Helen and then hope we can see who else it is?
Hiya. I just wanted to raise again with the outcome measures. We have problems with where we do perhaps 2 assessments and then discharge. Obviously, that's then bringing our compliance down. And if there's a way that can be resolved, obviously our compliance is showing very low, specifically with Core 10, because we're not doing that second measure.
I'm really sorry if that was at me. That went really crackly just partway through. Sorry.
That's okay, I'll repeat it. We're having problems with the second outcome measure, specifically for Core 10. purely because we do assessments perhaps over 2 sessions for whatever reason, and then they're discharged. So of course that's potentially 3 contacts without a second measure, which is obviously bringing our compliance down. But that patient would not be suitable to have a second outcome measure completed.
So they wouldn't, yeah. So for the national CQUIN, they're eligible, but actually they're not, based on the intervention that they needed. Is that?
Yeah.
Yeah. I don't know. And they wouldn't, yeah, it wouldn't count. But I mean, are there large percentages of women access service that would have 3 contacts?
There are, because we also do a very detailed screening appointment. So that is a first contact. Then there's the assessment, which is the second contact, potentially a second assessment, which is a third contact. And then it may be that they just required a medication review, 4th contact, and they're discharged. So in that time, there's not opportunity to get meaningful outcome measures. Obviously, the whole idea of them is that they measure the improvement of that patient, which over just 2 or 3 very quick contacts can't happen. So that's obviously bringing compliance right down.
Yeah. I mean,
has anybody on the call got any ideas for that one? Is that something other teams experience, or if anybody found a workaround for that? Or
I don't know if it's okay. I mean, I was going to start typing, but it might be easier just to speak. But I think one point that's worth noticing is measuring doesn't imply an expectation for improvement. Measuring is measuring, and if there's a reason there wasn't a clinical improvement because it was 3 scores, that's okay. So I would iterate that actually taking if it had to be that it was core, taking a core after a 3rd session just as a repeated measure, the fact that there isn't any clinical improvement because no clinical work has taken place is not part of the CQUIN. It's just that 2 measures get taken. So it's almost like separating off those 2 concerns. It's a concern, but it's not CQUIN dependent. And also, I think the other thing we discussed in Bucks was the choice of what measurement we were doing. So one of the options was HONUS as well, the clustering, because we've got a very high level of completion on that. But as a clinical representation, the data we take as a team, the one that gives us the most richness of our performance is core, but we do that anyway. So from the perspective of CQUIN, we're going to go with HONUS, is my understanding at this stage, because it's something we can do at beginning and end, and it's very embedded into the clinical practice, because this is about taking a measure as opposed to having an expectation, as in some services, of recovery is assumed to have been identified by the second measure.
Thank you. And there's three hands. So so there's Joe. Joe, is that a new hand?
It is. It's just a quick addition to your conversation about the telephone contacts. I just feel that there's a really significant part of our work. We do it by telephone. I understand that some people may offer video conferencing, or pre-COVID would have offered face-to-face. But the preconceptual counselling, or the counselling regarding medication use in pregnancy or when breastfeeding for women where there isn't necessarily a safeguarding aspect to that care, that we're not assessing them with their baby, we offer that via telephone. And I just think that it makes such a, well, from the anecdotal feedback that I've had from women and the feedback they've sent back into the team, it makes such a difference to their care, yet we're not able to capture that as either measure or actually as real data for our team, because we're doing that via the telephone. And I completely appreciate what Giles's concerns about telephone work and why video and face-to-face assessments are preferable. But for those one-off significant pieces of work, I do believe that telephone contacts are really valid.
Yeah, it is. And then how do you distinguish that in national data where it's those really meaningful contacts, or there's just a less than 5-minute potential triage to it is really tricky. But yeah, 100% agree. It's not that that work isn't really important, and I think, yeah, Jenny, maybe on the clinical leads call, this is something to kind of explore more from that side.
Sorry, can I quickly mention, I'm a pharmacist for the Berkshire team. So I offer women either telephone or video consultation, and then depending on their response, to be honest, 100% of the time it's phone call. They just want to have that conversation. But because I've offered it, I still record it as an online Skype consultation. So it still counts towards our access rates, because it can take me 3, 4, 5 hours to kind of speak to a woman, write up, communicate with the GP. It's a huge piece of work. So I would encourage a pharmacist to record it.
I have a pharmacist, but I completely agree with what you're saying, Becky. I offer that as and the other consultants in the team offer that conversation, and like you say, it is a huge piece of work, but currently it's not counted in our data because it's recorded as telephone contact.
Yeah, no, you should be recording it as a Skype online consultation. That's how we record it through Rio. As long as you're offering a video consultation, that should be enough.
Should I be there? I'm not sure if that's...
Is that right, Mary? Is that right? Or is it a bit cheaty? Or is that okay?
I don't know if I mean...
I speak to 100 women a year, and if it takes me 3 to 5 hours kind of to manage that woman, and it may be just that one-off contact, that's a huge amount of work that is not being counted otherwise.
Yeah, I'm nodding seriously at home.
Yeah, and I guess it goes above me to answer whether that I mean, it's definitely not, the metric shouldn't be implying that work isn't valid. It's whether the metric, what the metric is counting in terms of access. So does it recognise that work has already been accounted for in national modelling, but actually what the metric chooses to count is something separate to that. And then what's the impact of attaining this if we're not considering that work correctly? I don't know. It does go beyond me in terms of whether there is scope or an evidence base for shifting this metric. Right now, people above would say no, but maybe that needs to be revisited.
So if you can bear it, I would say capture it. Let us know, just try and keep some sort of tally of how many, how long those interventions are, and if you get any sort of narrative feedback from the women about how they receive it, I think that would all go towards us helping to sort of make a move on this potentially.
Jenny, I've been collecting data through SurveyMonkey, and it's how I got my job sort of made substantive instead of it being a pilot. It was based on the feedback that I've got.
Brilliant.
I have a huge amount of data to support this kind of work, and we've been fighting for this for 3 years to get it acknowledged. It's really frustrating, to be quite honest.
I agree. It's really frustrating. Feels like we're banging our heads against a brick wall.
To march on Skipton House when,
and like percentage of time spent on contacts unrelated to the metric would be really helpful data. Yeah.
But I think all of this argument and conversation has happened in other teams and services, and I'm always struck by this idea that we can't properly risk assess, or any of those ideas or thoughts that if we're doing this over telephone versus digital, because it makes massive numbers of assumptions. Was the baby on the lap during the digital set? Yeah. All of that, and these arguments have all happened within IAPT. Yeah, so curiosities about comparing a 5-minute conversation to a 20-minute conversation all happened within IAPT, and it's very simple. You just say you class it if it's over 20 minutes or if it's over 30 minutes. IAPT has already been through this, and that's how they get their triages counted, their brief screening assessments. It has to be over a certain length of time. It can't be a 5-minute. And I think when you step back from this, you have to think about what's the function of this metric. Is the function of this metric to ask us how many women are accessing our service and a quality of a service that's high, or is it the function to enforce a position that says we must do face-to-face or digital, even when the women don't want it? and counting and metrics shouldn't be about enforcing, you could say, like a political or a viewpoint upon people. It should be a representation of activity, and at the moment it's not a clear representation of activity because it's enforcing a position.
Yeah, I do agree. Ultimately, a metric shouldn't in any way dictate clinical work, even if, you know, it's going against what the metric is trying to achieve, if the clinical work is kind of away from that. So I agree. I would say, you know, we have to be careful about comparisons to IAP. There isn't a timestamp on the way they collect their data. So length of telephone, it's more, it's got to be 2 contacts. And then again, that's still making huge assumptions because it's assuming 2 contacts means someone's entering treatment, which it might not necessarily do, as we've had from the conversations about the CQUIN with 3 contacts.
But you can't, because I've worked in IAP, you can't log a contact if it was just a call. You can't say, like, if you're phoning them for 5 minutes to arrange something, that counts as the clinical contact. So it's in there in the baseline.
Yeah, in local, in local systems it would be. But we're obviously seeing very, very different cohorts of women in terms of severity. But I do agree, is it there to capture actual activity, or is it something else that's based on assumptions? I don't know.
Okay, we've got one more hand up, which I'll take this question from Becky, and then I think we really need to move it on because I don't want to keep you too long, and we just want to make sure we've got a plan going forward for the access targets. Okay, so Becky.
Sorry, Jenny, that was my hand up from before. Apologies.
Oh, okay, that's fab then. And we got Barbara. That's naughty because I said one more. Okay, Barbara.
No, sorry, it was just to just a quickie. I think I appreciate all the comments that have been made, and Mary, thank you so much for fielding them. But I think this is something that needs to be again escalated back up to Giles for further consideration and further discussion. So I'm not sure if it's best to have it with the clinical leads and then take it up from there.
Yeah. Okay, let's have the next slide, please. Is that one of yours, Mary?
No, I think that's
the
me.
same
I know
one.
that there was going to be, so there's just appendices on the slides just for information. But we can go through them if we like. But yeah, actions for me before I go will be to come back on those questions around the CQUIN. Apologies for not being prepped on those. I was unaware of my slot being so large today and have been on holiday nicely for a week before this. So sorry for not being more detailed on the CQUIN, but I will definitely come back to everyone on that.
Okay, Mary, do you want to talk to this one?
Yeah, I can do. Barbara, am I right? You said there were going to be commissioner discussions. There was something separate. Have I got that wrong? Do you want me to talk?
No, you got that right. I mean, what we're hoping to do is following on from your presentation and a couple of the key things, such as a dashboard, etc., for systems to go through and start actually interrogating their data. What we wanted to do as a region was to have those conversations with the systems to see where they are at the moment and see if there's anything we can possibly do. So, for example, if they've gone through all this information and it looks like the access numbers are correct and they're doing everything correct, everything is where it should be, that's a flag for us to say, okay, so if we're not meeting the access growth, is it a case of, do we need to look at workforce? Do we need to look at expanding our sites? I know there is also ongoing issues, don't want to use the word issues, situations with regards to investment or lack of investment. And that is, again, something we will have to look at. But we need to do this step first in order for us to look at how we can improve things going forward. If that makes sense.
Yeah, so Loki, you're wanting to look at the access numbers based on last year, and then understand what kind of growth is expected for 2021 and what's needed to support that.
Yeah, so if the systems are doing everything correctly, there's no data quality issues, but we're still sort of about the sort of 4% figure, then we need to look across the board about what we can do to improve it. So I sort of need systems to start looking at their data now so we can support them going forward in trying to help with their access numbers if there's not a data quality issue, and there's no issues with regards to how they're adopting the contact metrics.
I'm just going to move our slides forward to that. So, because I think we've had quite a bit of discussion about what are the challenges in achieving the target rate. Can we go forward to the next slide, which is exactly that, what Barbara was just talking about, in terms of what support systems feel they require to achieve the access target rate, and what can we do locally, regionally and nationally. So our intention is obviously to have further opportunity for these webinars as the in between webinars to our excuse me, our main monthly webinars, but also to have that offer of individual service and commissioner meetings to really drill down into the data. But as we've said all along, that's as a support mechanism, not as a you know, kind of to be beating you with a stick in terms of your current data. It's absolutely how do we work together to make sure that the data that we're capturing is clean, that's being fed through, and what else we can do. And I guess really for us to ask you if you have any other ideas as to how best we can support you with this in terms of taking it forward. Any other thoughts from anybody?
If it's okay to share, yeah. I think the one thought / concern I have is that in the conversation about the expansion and the meeting requirement to sort of have access to more funding to deliver more as the perinatal team, I think one of the things that feels like it can be tricky is having that conversation that at the moment for many of us, and it would seem 5 out of 6 STPs, we're not reaching and meeting what we're already meant to do. And the problem is if that information is wanted to be used as an argument why not to release funding, we're sort of caught in a little bit of a tight spot of arguments with whoever it may be, whether it's commissioners or people around us and above us, who may be saying, actually, I think you need to get your ducks that you already have in a row before you ask for more ducks. And that therefore means that this issue about our current reporting and our current access and how that access gets counted, i.e. digital, telephone, all of those difficulties, that's then informing the difficulties as we're moving forwards. It's like our current difficulty is now making our future journey more complicated, and it's quite frustrating and concerning.
No, I appreciate that. Can I ask, I know this is a controversial question, but I'm going to ask it. Are people receiving, I know we've looked at obviously regionally that we look at what monies are due to come to services and what have actually gone to perinatal mental health. Are people having issues accessing the money that is intended for perinatal mental health? Or happy to pick that up offline if people would prefer to? Okay, that's good to know. So if you likewise, if you are getting, if money is flowing as it should do, that's also really important for us to know. Yeah, but do flag to either myself, Jenny, or Barbara if there are issues, and we're happy to have conversations. I know it is a challenge, when it goes into the mental health pot and there are competing priorities for commissioners. Okay.
And it may be worth services looking at the interesting demographic information on the dashboard, because whilst for a lot of areas of the East, having 68.5% of women identifying as white or white British is probably not an issue, because we know that we've got particularly I know for Hampshire, there's a much higher proportion of white British than the national average. So that might be okay. But if you look at other inequalities, then you might find you've got underrepresented groups, and that you need to be targeting your service to a slightly different group, and that might help with your numbers. So it's kind of looking at it quite holistically, I think. You know, are you capturing everything accurately? Are you reaching out to those marginalised groups that we've been talking about over time, who might just be missing out? And that might help with numbers. And of course, the maternal mental health services will help with the numbers as well. So hopefully, Lauren, that I know that was sort of your question, but that's a bit of investment with that should have results for this for people.
Yeah, I agree, and I think it's that sort of ducks in a row was one of the things that came back even around those conversations. I think was sort of we need to be making sure our access figures are meeting what the targets are saying before we're thinking and planning ahead. So it's just a response I know that comes when we project and plan in line with expansion. It's a response that can come.
And that's particularly significant for wave 2 sites, you know, that are still sort of potentially bedding in and really getting going. So we do understand that.
Yep, thank you.
Okay, so Jenny, sorry.
I was just going to say, has anybody got any successes with the access target that they can share? Anybody doing any quick wins in terms of how you've got your staff recording accurately, how you know you're covering it in supervision, what's happening at that level that might be good to share with other services? You've all gone quiet now. We need to talk about Em. Okay, hi Em.
Oh, hi, I'm not sure if this you're looking for or not, Jenny. I suppose since the in the context of COVID and everything, we've increased the volume of our groups online, which means we are having a lot of contact with people that way. And we've developed more groups than we were offering sort of pre-COVID, so that's what we're having a lot of contacts through those. So I'm not sure if that's what you were looking for or not.
It's important to remember groups.
I can give examples if you want, but yeah, we've definitely, I think it's been easier to set up and offer groups, and over our large geographical footprint, make them much more accessible. So I'd be interested to see how our uptake has improved. But yeah, I think that's another way we sort of been increasing contacts.
And Becky's saying in the chat box, operational support to make sure people outcome appointments, really important, really simple, but really, really important. And Jo, you've got your hand up.
Something that we in Hampshire that we copied directly from Dorset, so I can't take any credit from it. But we at one of the network meetings, Dorset had basically seconded a member of their staff to really focus on data and outcome data and collecting outcome data and making sure that all the staff were on it in terms of the outcome measures being consistently collected. And so we've used some of the transformation money to employ an assistant psychologist for the team, and part of his role, he's on the call as well, and part of his role will be to improve our performance in terms of outcome measures, because I know that it's not always a priority, but it's absolutely essential that we're doing it.
Yeah, that's me. Hello, everyone. So yeah, obviously this call's been really useful, and I'm just looking at getting started on how I begin really with kind of almost a kind of persuasion wave of trying to get people to adhere a little bit more to the kind of the routine of doing these outcome measures pre and post. As you said, it's already good to know that we're doing it well, but obviously if we do better, then that is better. And I guess some of the things that I'll be looking at mainly is looking at where would be a realistic point to start, rather than overfacing everyone and asking them to do heaps of outcome measures, starting with maybe favouring the core 10 rather than the 34-point score, and just asking people to do those as a minimum at the start and at discharge, rather than what NHS England would ask for, which is like monthly measures. And that's going to be something that I'm going to be putting forward to the team in the next month or so, as well as also more use of poems as well. And obviously as Joe's just said, I'm fairly new to role, so I'm figuring out the kinks and the different ways of doing this. And having looked at it a little bit, it looks like digital is better in terms of saving clinician time, and it's figuring out the best ways of doing that, using software such as SurveyMonkey or perhaps even Qualtrics. And I'm also going to be looking into what we have on Rio as a standard in terms of outcome measures, because some of them you're not able to record on Rio in this trust. And I have seen on other trusts, Rios, they have outcome measures such as the 34-point core OM that are just there, easy to fill out. Whereas I know some of the outcome measures that we have here in Southern Health Trust, you just got a little box to do the overall score if you know where to find it, which can be quite hard to find as well for staff. So looking into, yeah.
Sorry, I'm just really mindful of time, and I know others will have to get on to other meetings. So can we maybe invite you to come back at a later stage once you're further into this work to talk about it?
Yeah, no worries. I was rambling on there.
No.
So much to say.
Thank you. Thank you for that. So in terms of next steps in that, so we will get the information sent out from Mary in terms of the CQUIN and what have you. We will also set up some further webinars throughout the year in terms of these additional webinars to come back and revisit, and we'll look at what individual, please email us about what individual support you may want as well in terms of individual visits, meetings, etc. As always, the slides will be available. They'll get sent out. Apologies for those of you that were on the monthly webinar last week. There has been a delay in those slides coming out, but they will be coming out shortly. Also, just the next slide, please, Sarah. Just a reminder that our next monthly webinar is on the 21st of October, which is focusing on safeguarding. And just a plug, please, can we encourage you all to get your safeguarding leads along to attend, or at least to watch it afterwards if they're not able to attend on the day. So just want to bring us to a close because I appreciate that people need to get on, but a massive thank you for Mary's time today and really useful presentation, and also Barbara, thank you very much in terms of regional support and presenting the data. We will be working collectively on this to take this forward, so thank you all for your input today, and we will look at those continued challenges that we have in terms of some of the data, and particularly the telephone consultations, etc. Thank you all and wish you a good day.
Thank you, Mary.
Thanks, Liz. Thanks all.